I've been on creams, the whole twice a day application, shaving the scrotum. I've done it, guys. Your boy has done it. I'm telling you, it's traumatizing. The first couple times, you get used to it, okay? But I did a perfect application for a whole month. Welcome to Hormones Happen, the no-fluff podcast for men and women who are tired of feeling stuck in someone else's body. If you've been dragging through your day, struggling with stubborn weight, low sex drive, brain fog, or just feeling off, you're not crazy, and you're definitely not alone. I'm a nurse practitioner who's helped countless people transform their lives through hormone replacement therapy, and I've been through the journey myself. Here, we cut through the confusion, ditch the shame, and talk real solutions. Because it's time to stop just surviving and start thriving. This is your moment to be the hero of your own story. Welcome back, guys, to Hormones Happen. Today, we're doing part 2 of the 2-part series of the initial patient intake. In part 1, we talked about what might lead you to a hormone replacement clinic. But then we also went over all the labs that we get, why we get them, and what it means. Now today, we're going to talk about treatment options, right? We're going to be talking about injections, creams. I'm even going to talk about orals, even though I don't provide them yet, and just give you an idea of what do we actually do to replace your hormones. And I'm going to give you little pearls of wisdom, little tips and tricks. So maybe you're already on TRT and it's just not working that well. Maybe instead of jumping ship to another clinic, maybe you implement these first. Who knows, guys? But without further ado, I'm going to stop talking. Let's get into it. All right, guys. So we just talked about your labs. We've established your testosterone's there, right? But it's not gone. It's not zero. It's not even less than 250. So should we just send you on your way and say, sorry, come back in 10 years? Nah. No, with your symptoms, right? You're not sleeping. You're having decreased energy during the day. Libido's crap, right? Relationship problems now. Work is becoming a struggle. Brain fog, depression that you're just not willing to tell anyone about. Anxiety? You're anxious now? Wait, guys get anxious? Of course they do. Now it's time to actually fix the problem. Well, you're in luck because we have tons of different options. The one thing I'm not going to necessarily talk about are pellets, because pellets for guys, it exists, not very common. And so I'm going to talk about the ones that are more efficacious or effective. Let's start off with injections, right? So injections, it's an injectable testosterone. There are several different types of injectable testosterone. If you're actually watching the video, I'm going to show you what a vial looks like. This is what a vial of testosterone looks like. And believe it or not, there's a couple things in there, guys. There's the medication, which is testosterone. There's the ester, which gives it its time-release properties. And then there's a carrier oil. And so how does all this work? We've already talked about testosterone, right? It does several things. It improves your muscle mass, decreases body fat, improves your mood because it increases serotonin reuptake transporters. Same mechanism as a Prozac, okay? A lot of other downstream things because of the estradiol and DHT, which we talked about last time. But if you were to inject that without an ester, you would get it all within a couple minutes. So an ester is an enzyme that gives it its time-release properties, and there's several. There's propionate, enanthate, cypionate, and decanoate. Specifically, I use cypionate. In some patients, I do use enanthate. The reason I use cypionate is because we know that in 3 to 4 days, it's going to be at its peak action of onset. And we know that in 7 days, half the medication is going to be out of your system. We call this a half-life. And so one flaw that I see time and time again is people will inject this once a week. So they'll be way up here, day 3 to 4, day 7, they'll feel like crap, and they'll just roller coaster, okay? That fluctuation in your hormones, not only does it make you feel like shit, but it's going to increase the risk of acne. It's going to increase that degree of erythrocytosis, which is not dangerous, we talked about. And we just don't want to do that. Think about the last time your hormones fluctuated. You were a teenager. Teenagers don't make great decisions, guys. We don't want to be teenagers, okay? And so cypionate is a very tried and true ester. Now, I recommend twice a week injections, at least twice a week injections. And I know that's kind of a tall order, right? Like, crap, I'm going to be poking myself twice a week, at least, guys. But look, there's a way that we can do this to make it easier. The carrier oil. There are a lot of carrier oils out there. So testosterone is what we call hydrophobic. It has to be carried in either a fat or a protein. And so it gets carried with oils. And there are some really shitty ones out there, like cottonseed oil, sesame seed oil. You go to CVS, Walgreens, Walmart, that's the oil that's going to be mixed in your testosterone. I specifically use grapeseed oil because it's less viscous, meaning less thick, and it's non-inflammatory. There's other good oils too, like MCT oil. These are good oils. These are thin, non-inflammatory oils. And because of that, guess what? Hormones are tricky, guys, and things are always changing. To stay up to date, check out the blog on stillcity-trt.com. Now back to the podcast. You can inject this subcutaneously. In the fat tissue, guys, we get to use insulin syringes. These are the same syringes that people inject insulin, semaglutide, tirzepatide, growth hormone, peptides, same thing. It's a small little needle, and you really can inject into the fat tissue. Just pinch up a little fat in the belly or the back of the arm, put it right in. I have a lot of guys that do that. The only difference between fat tissue and the muscle tissue is that the muscle has a greater vascular supply. It's going to absorb a little bit quicker, okay? But it doesn't matter because remember, we're injecting twice a week. Now, I will say that levels are going to be exactly the same. I've seen this in clinical practice, and they've shown it in studies, whether you do sub-Q or you do intramuscular. Some guys, myself included, I feel better with intramuscular. I've done sub-Q many, many times. It's fine, but I feel better with intramuscular. And one other caveat to sub-Q is some guys are going to be a little sensitive when you inject into the fat tissue. Maybe not initially, but over time. And you may get a little bit of local site irritation, some redness, some heat, some pain to the injection site if you go subcutaneous. Now, one way we can avoid this is really making sure that you use proper injection technique. Alcohol swab to the top of your vial, the area that you're injecting, let it dry, then inject, okay? But when you get that local site irritation, not only does it suck because it hurts, but there's also the thought process that as your body's making all these inflammatory mediators, it may not be absorbing the medication as well. So that's a possibility you got to think about. Like I said, it's happened to me quite a few times. I strictly go intramuscular shallow IM with the 27 gauge half-inch needle, aka insulin needle. It works just fine, but everyone's going to be different. You might get a little bit of what we call a nodule, just a little bump in there. That's just the oil depot. Rub it out. It'll go away. It'll go away on its own. Then the next thing we need to think about is, well, what if I'm deathly afraid of needles? Well, now what? Well, you're in luck because we have creams. This is what a cream looks like. This is a testosterone cream, and it has a blue top because of it. Estrogen is pink, but not always. I work with over 15 different pharmacies, and I've seen probably 10 different variations of this cream. It all essentially is the same. The cream comes out of the top. The lid pops off. Cream comes out of the top, this bottom. And of course, if you're watching the video, you're able to see a lot of this good stuff, is a clicker, okay? And what I mean by that is every time you turn that dial, you're going to actually hear an audible click. And that click is your dose being administered. And so we can concentrate these however we want, because remember, we're working with compounding pharmacies, guys. That means the sky's the limit. And I'll talk about that caveat in a second, but I typically start my guys off with a 20% concentration. You know, that's equivalent to about 200 milligrams per dose, which is going to be 4 clicks, 1 gram. And so you typically administer this 2 clicks twice a day. Now, not just anywhere, okay? And it's important that I tell you about this. We are actually not using androgel, okay? Androgel is completely different. Androgel is a alcohol-based gel, very underpowered. It's like maybe 1, maximum 2% concentration. This is 20% concentration. It's a cream, water-based. So unlike androgel, which a lot of guys will put on their shoulders, we're actually putting this on the scrotum, guys. It's water-based, okay? You never put androgel on the scrotum, but these creams, you got to put them on the scrotum. And you don't have to, but if you want optimal results, I recommend it. The scrotum is a very thin vascular membrane, but let's add one layer to that. Now we're going to shave it, okay? Every other day. And I'm not talking clippers, guys, okay? Clippers are brutal. That just one shaky move and you're just going to eat that shit up. So razor, okay? We need all the hair gone. And I know it's like, but why? Any cream that's on that hair, guys, is not going into the capillaries. And if you want maximum results with these creams, we gotta get it in the capillaries, okay? A lot of people think creams are pretty shit. I used to as well. I got several patients with testosterone levels over 1,500 by good application of the creams, okay? And there's a lot of variables to that, right? You have to have the skin quality, the texture. There's a lot of things to it. Not everyone's going to get it even with perfect application. But if you're the kind of guy that says, look, Jeremiah, I can apply this cream twice daily to a shaven scrotum, you are a perfect candidate for this therapy. And what's the difference? So one, we're not poking ourselves. So that's one benefit of cream. Two, you're never going to get steadier levels, guys. Cream is as steady as it gets because we're applying it twice a day. Now, even with injections, twice a week is pretty damn steady. Some guys do 3 times a week. I've done every other day. It does become a little bit of a burden poking yourself every other day. I've been on creams, the whole twice a day application, shaving the scrotum. I've done it, guys. Your boy has done it. I'm telling you, it's traumatizing. The first couple times, you get used to it, okay? But I did a perfect application for a whole month. And when I got my labs done, right, I checked my labs. I usually run around 1,500 on my testosterone. I was about 1,000. I honestly did not feel the drop. I did not feel significantly different. I did definitely feel the steadiness. I felt more kind of, I guess, even keel perhaps.
If you're serious about optimizing your health, don't stop here. Visit stillcity-trt.com for in-depth information on all things HRT and TRT. Now let's get back to the show.
I felt it. And, it could be placebo, right? I could just be talking out of my ass here, but I noticed it. Now, the problem is it's rigorous, because if you apply it in the morning, then you got to go do something like yard work, and then you go shower. You're like, well, do I reapply it? What do I do, right? You want at least 6 hours of skin to cream contact for that to really get the maximum absorption, okay? So, I typically recommend shower, apply the cream, refrain from swimming, anything that's going to wash that cream off for about 6 hours. Well, you don't really have to worry too much about spacing it out too evenly. It's pretty forgiving. Could you do an additional click? Sure. What if you miss a click? Oh, it's not ideal, right? Because at that point, we're not maintaining as much steady. We're kind of doing this little maneuver. So creams are an amazing tool if you're very, very regimented and you're going to go ahead and you're going to stay into that routine. Now, both give great results. Levels are going to be higher with injections, and simply because sky's the limit. Now, like I said, we work with compounding pharmacies, so we can compound these sky high, right? But at what level does it become unsteady? So what I mean by this is there are some pharmacies that will compound that cream to 22%, 25%. I think I've even seen 30%. And so realize when you're making a cream, you got a powder, you put it in a liquid, it becomes a cream. Now, 20% is probably the highest concentration that's going to remain stable. 22, 25% sound great, but you're going to get some precipitation and it's not going to be stable. You're probably not getting the benefit. And those creams get expensive, so it's probably not worth it. So with creams, there is always going to be that ceiling. Okay, there's always going to be some kind of ceiling with the cream. As we're with the injections, I mean, honestly, literally the sky's the limit. Bodybuilders are using grams a week, right? That's not TRT by any means. But, I treat guys all the way from 200 milligrams a week. I've got some guys at 280 milligrams a week. I've been there myself. I don't believe in just capping at that 200 because there are a lot of guys that aren't going to get benefits there. A majority will. I'm going to say probably about 75% of guys will achieve results at 200 or even a little bit lower. But there's going to be that 25% of guys who just need a higher level because it's all relative, proportional to where you used to be. You get a 60, 70-year-old guy comes in, his testosterone when he gets on therapy is like 400. Back when he was 20, he could have been 2000, right? So to really kind of optimize, I do push up a little bit higher. Of course, I'm monitoring these guys very, very carefully. And really the main thing with increasing dose like that is side effects, right? So when I was at 280, felt good, but I started getting a lot of acne. I've always been prone to it. So a lot of backne, as we call it, acne on the chest. When I got one little lesion on my face, that's when I was like, fuck this, I need to go down. Needless to say, I'm down to 200 milligrams a week. I still feel great. And that's the thing, right? Higher's not always more. I have a lot of guys who will kind of think like, let's get to the 280 because it's the highest dose. And that's not the goal. Let's see where you feel at, 220. Oh, I feel just as good. What about 210? Just as good. 200. Oh yeah, I feel much better. And it just depends. Everyone's different, but the thing we have to consider is genetics, androgen receptor density, androgen receptor sensitivity. These are all things we can't test for, right? And so as long as you're being monitored carefully, it's completely fine, guys. I've only got a handful of guys less than 200 that achieve optimal results, but everyone's different. So now let's talk about orals. I know I said I don't offer the orals because I don't, but it's gaining a lot of popularity, and this might be something that does come to the forefront. It's called Kysotrex, and it's actually a testosterone undecanoate. So what that means, it's a very, very long ester. I want to say it's like 28 carbon atoms long, something along those lines. And because it's such a long carbon chain, it actually bypasses liver circulation completely and gets absorbed through the lymphatic system. So this is exciting because this is an oral anabolic that is safe for your liver. I've talked to a lot of urologists about this, and it's got what we call a bimodal peak distribution, where basically you take it and you have a peak, it drops, you take it again, it peaks, it drops, okay? And so because of that, there's the thought process that it may not actually turn off your natural endogenous production. And once again, it's very unclear. I haven't gotten a straight answer on that. But what does that really mean? Does that mean that we can be on exogenous testosterone and still maintain our fertility? That's kind of an interesting concept. And even on any form of testosterone. Let's get real for a second. Yeah, aging happens, but feeling exhausted, struggling with sleep, losing your edge in the bedroom, and watching your confidence tank, that's not just getting older. That's a hormonal imbalance, and you don't have to live with it. They'll tell you hormones are dangerous, but hand you a prescription with a mile-long list of effects. Enough is enough, guys. At Steel City HRT and Weight Loss, we cut through the noise. We offer safe, bioidentical hormone therapy customized to you and backed by real lab monitoring and personalized care. Because your health isn't one size fits all. If you're done with the BS and ready to feel like yourself again, strong, focused, and confident, call or text us at 719-669-4223. Let's build a plan that actually works for you. Steel City HRT and Weight Loss. Be the hero of your own story. It's not birth control, okay? It's going to decrease your fertility as your intratesticular testosterone decreases. So I'm just going to backtrack and explain that real quick. So when you're on an exogenous form of testosterone, whether it's injection, cream, oral, your brain doesn't know that. Your brain's like, dude, I'm making way too much testosterone. And the only thing it can do is stop making LH and FSH. And that causes a decrease in your natural testosterone. We call it shutdown. Now, that decrease in your natural testosterone results in decreased intratesticular testosterone. That's why the testicles shrink. Other than, just being a cosmetic thing, it does decrease fertility because we need a lot of intratesticular testosterone for sperm health. Our intratesticular testosterone, I know I'm getting real tired of saying that word, is about 100 times higher than what's in our blood. Okay, so it's very, very important for sperm health. Do I have a lot of guys who have children after TRT and they didn't before? Hell yeah. So it's not birth control, and that's important to know. But if we can be on some degree of exogenous testosterone while maintaining our endogenous production, is it really even enough? Is kind of the question. If it's not turning off our natural production, which we make anywhere between 2 and 10 milligrams of testosterone a day, I don't really know how effective it would be. It's gaining a lot of popularity. It's pretty expensive right now because it's brand name only, but eventually this may be the main form of therapy. If I could avoid poking myself or applying cream to my nuts, I will take the pill twice a day. It is twice a day. I know there's 2 different doses, 2 different formulations of it, and that's really about it. I do know that a lot of guys actually take it morning and afternoon because of that bimodal increase. Not a lot of guys want to peak their testosterone in the middle of the night. So normally instead of taking it morning and night, they take it morning and afternoon. And then at night, their natural production or their exogenous, I'm not sure, falls. So we'll see. As I get more information on that, I'll let you guys know. But right now, creams and injections, we know them very well. They both work very well. They both have their own specific caveats to it. And then we have some adjunct therapies too. Like what about enclomiphene? What about HCG? I hear guys ask me about these. Enclomiphene, so just kind of a little bit of a educational thing, is not the same as Clomid, okay? Clomid is a combination of enclomiphene and zooclomiphene. One of the biggest issues with Clomid is that people were getting, or should I say men were getting mood dysregulation because enclomiphene and zooclomiphene essentially have 2 different mechanisms of action, right? One basically antagonizes estrogen receptors, one agonizes it, and they have different half-lives. So it's kind of conflicting and it causes some, I guess, mental distress. Enclomiphene is just part of it. And enclomiphene has the same amount of results. It basically tricks the brain into thinking that your estrogen levels are low. And the only way that the body's going to make more estrogen is by increasing the testosterone. Because remember, like we talked last time, you do make small amounts in the testes and adrenal glands. Majority is from aromatization of testosterone. So the brain thinks, okay, well, I need to make more estrogen. So in order to do that, I'm going to make more testosterone that converts into estrogen. And so that's what enclomiphene does. Now, long term, I'd say a lot of guys get their best results in the first couple months, and then they're like, get me on testosterone, please. HCG, human chorionic gonadotropin, hormone made from the placenta of a female. In a male, it acts as luteinizing hormone. Our body basically thinks it's luteinizing hormone. And so what it does is it stimulates our testes, specifically our Leydig cells, to make more testosterone. So a lot of guys will use this as an adjunct to testosterone, mainly for fertility, because we're going to go ahead and increase our intratesticular testosterone. The testicles are going to get full again. But I've also heard, never been on it, I've heard it really kind of helps with just augmentation of the testosterone. You feel better. Mood's more stable. You sleep better. Hard to say. I guess it makes sense when you're getting testosterone from 2 different pathways. But what about using this as a monotherapy? Can you just use HCG instead of testosterone? Possibly. It really depends. Because what we need to realize is if you have a primary hypogonadism, meaning your testes are the problem, you could throw as much LH as you want at those bad boys. They're not going to produce. So that's why it's important to get that blood work, because why waste your money on something that's absolutely not going to work when you know the issue is the testes? So I'd say in a situation where you have a primary or some degree of it, the testicles are the issue, HCG is not going to help you at all. So testosterone's tried and true for primary and secondary hypogonadism. We are at the mark, guys. This was part 2 of a 2-part series. Next, I'm going to do initial intake for females. So tune in, ladies. Men, you can still tune in too. It might help you. That's a wrap on today's episode of Hormones Happen. I hope you're walking away with some clarity and confidence. If this resonated with you, let's keep the conversation going. Connect with us on Facebook, Instagram, or over on the blog. And if you haven't yet subscribed yet, go ahead. It's the easiest way to keep growing and learning. As always, we believe in your power to heal, thrive, and lead. Be the hero of your own story.